pre-op chemotherapy can lyse the tumor and tumor disappears, then how can we plan for breast conservation?
That's why we have to put a clip for all pre-op chemotherapy. Ideally, we have to put a clip.
Clip at
Inside the tumor, sir.
inside the tumor
There are 4 clips to be placed on all edges.
edges.
But clip is costly. That clip is one clip will cost 10,000 rupees. So
Okay.
what we do is put a clip at the center of the lesion
Lesion.
and do a wide excision.
Wide local excision.
Yeah, or do a wide local excision.
From this, how many centimeter we can plan from the center of the clip?
It will not disappear as you think. Only triple negative breast cancers have a very complete response.
Response.
Yeah, for ER/PR positive tumors, LABCs only we will plan for neoadjuvant chemotherapy, and most of our LABCs, ER/PR positive tumors, have a static disease. They don't much respond to neoadjuvant chemotherapy. So you will be having some tumor to guide you for the wide excision. So for triple negatives, the problem is there. So you have to see the pre-op scans. Pre-op scans, if it is 3 centimeters, you have to take those volumes. It's not like 2-3 centimeters later.
Okay. Then you say about the sentinel node biopsy, and you can remove the part of the node and left the non-positive nodes inside the axilla. Whether how can we confirm whether this node can recur or node can become positive or metastase later?
This sentinel node is called sentinel because it is a first
First
echelon node
node.
to drain the
Drain the
area. And everyone is afraid similarly.
Similarly.
If I leave some other disease, what will
What will happen?
Yes.
Yes.
So that afraid has been asked many a times. There are multiple papers with thousands, 10,000s of patients where sentinel node has been done, actually not completed, and they have not recurred during the recurrence if at all they got it. They have not recurred in the axilla. The axillary nodal recurrence is 0.04%. So you can be sure that if you are doing a proper sentinel node biopsy, there will be no axillary recurrence. This is what we give to the patient. We say to the patient. If I am counseling a patient for BCS, I have to say that the patient will require radiation. Versus MRM, the patient may not require radiation post-operatively if it is node negative. Similarly, for the sentinel node, I have to say that the chances for local recurrences, regional recurrences, less than 0.1%.
The word neoadjuvant chemotherapy is coined for LABC only, where we downstage the tumor. Where we go for the early breast cancer, there is T2N1 stage. We give chemotherapy first. Whether we coin the word neoadjuvant or adjuvant chemotherapy.
Neoadjuvant is for any patient, anywhere where we give chemotherapy before surgery. These things are become loose nowadays. Like the purpose of the word of neoadjuvant chemotherapy is something different. We are using it similarly for some other for other areas also. So loosely, NACT neoadjuvant is for chemotherapy given before any local regional treatment, which may be radiation or surgery.
I want you to explain one thing to the PGs, and I want to emphasize
Yes.
something to the PGs. You mentioned something about a specimen mammography. So can you explain what that is for the PGs?
I don't have a photo for it, but if there is a microcalcification, you have to take out the entire microcalcification if you're planning for a breast conservation surgery. So after you remove the specimen, you mark the specimen. Similarly, short superior. I do mark with short thread on the superior aspect and a long thread on the lateral aspect. Send that specimen for mammogram. They do similarly a mammogram similar to the mammogram done for breast females. So you have to see all the microcalcifications we got in the specimen mammogram with margins. If it is not there, you have to go and redo the specimen. It is just like a frozen section form.
So that report will come by the time the axillary frozen section comes.
Yeah, immediately. Basically, I used to carry as an MCH first year PG the specimen to the mammogram department, get the X-ray, and they will be seeing it in the console. And if the radiologist says all the microcalc has been got, we'll end the procedure, or else we'll do revision on whatever margins were there.
So that is an important point. Like you go in and do a surgery, you actually verify whether you have completed the surgery by comparing the pre-operative mammogram with the post-operative mammogram specimen in the radiology department, and all the microcalcification have been taken out of it. That is one thing. Another thing that I wanted to highlight what sir mentioned is in follow-up for CA breast, routine imaging does not give any additional advantage compared to imaging based on patient symptoms. So patient has a symptom related to lung or liver, you can do an imaging. If the patient says there are no symptoms, your clinical examination is okay. It is okay to not do imaging in the case of CA breast. So that he mentioned that, I just wanted to emphasize it. Thank you.
Thank you, sir.
Sir, after neoadjuvant chemotherapy, if the patient is a complete responder, will you go for wait and watch or will you go for BCT, sir?
That's a question for. We recently had this discussion in the recent TASOCON April 2025 at Mahabalipuram. I think you attended the conference, right? No. So we spoke for surgery and the other team spoke for against surgery. And that's a very important evolving topic. There is no currently local, RCTs, level 1 evidence. Level 1 evidence consists of a randomized, well-conducted randomized control trial or a meta-analysis. That's what level 1 evidence is. There is no level 1 evidence for not doing surgery in a complete response post-chemo. So we have to go and do a surgery for now, as of now. But yes, for triple negative and HER2 enriched, those are the areas where complete response is possible. Triple negative, actually they say that if you see a speculated margin in mammogram, you can say for sure at least 90% of the time those things will be hormone receptor positive, because hormone receptor positive tumors grow slowly and they have time to infiltrate into the adjacent areas. Triple negative tumors, when you do a mammogram or an ultrasound, it will look like a fibroadenoma, because they will be having a pushing borders, because they grow so fast that it will be having a pushing borders instead of infiltrating borders. So the same way, the way they grow faster. When you give chemo, their response also will be dramatic, it will disappear. But there is no evidence for now. We have to go for surgery now. Later on, we may get some evidence where we can omit surgery in TNBCs and HER2 enriched patients.
சார் சொன்ன மாதிரி வந்து இப்போதைக்கு லெவல் 1 எவிடன்ஸ் இல்லை. ஆனால் அதில் இன்னொரு பாயிண்ட் என்ன அப்படின்னா, நியோஅட்ஜுவன்ட் கீமோதெரபி கொடுக்குறீங்க, டியூமர் ஃபுல்லாக பால்பபிள் டியூமர் எல்லாம் சரியாயிடும். அதுக்கு பேர் வந்து கிளினிக்கல் கம்ப்ளீட் ரெஸ்பான்ஸ். அதில் வந்து சில சமயம் வந்து பார்த்தீங்கன்னா ஸ்கேட்டர்டு டியூமர் செல்ஸ் இருக்கிறதுக்கான வாய்ப்பு இருக்குது. அது வந்து கிளினிக்கலாக தெரியாது, ஈவன் பெட்சிட்டிலையுமே தெரியாது. ஸோ அதனால் இப்போதைக்கு சர்ஜரி பண்ணிடுறது தான் பெட்டர். ரேடியேஷன் வேணாம் அப்படின்னு ரீசெண்டாக ஒரு பெரிய பேப்பர் வந்திருக்கு, அது பின்னாடி நம்ம டிஸ்கஸ் பண்ணுவோம்.
Yes, sir, always. So they say on that day, like, if there is a complete response clinically and radiologically, what to do then? You do a biopsy and then wait for. There are a lot of papers which is coming, but currently there is no level of evidence to avoid surgery in such. Yeah. Yes. So the aim of any treatment is to reduce the amount of surgery or radiation or chemotherapy with the same oncological outcome. So we have achieved the peak of oncological outcome in breast cancers, especially in breast cancer. The oncological peak is achieved. So இதில் வந்து நம்ம டவுன் சைஸ் பண்ண முடியுமா, டவுன் ட்ரீட் பண்ண முடியுமான்னா இப்போ இப்போதைக்கு இருக்கிற எல்லா இன்வெஸ்டிகேஷன்ஸும் பண்ணிட்டு இருக்காங்க, எல்லா இன்வெஸ்டிகேட்டர்ஸ் தான். எஸ், ரேடியேஷனை நிறைய இல்லை கீமோதெரப்பியுமே அவாய்ட் பண்ணுறதுக்கு இப்போ நிறைய ஆப்ஷன்ஸ் இருக்குது சார். அதர் தேன் தட் 1 year chemotherapy is for HER2 trastuzumab. Trastuzumab is an aggressive tumors. So aggressive tumors, we have to deal with aggressiveness. Yes, sir. 1 year is the standard norm. I think Dr. Deena Dayalan will be evaluating that, because we have seen wonders where I had seen there are 13 node positive, HER2 positive tumors. 13 nodes is like, I thought that patient will be recurring within a year or within 2 years. Whatever treatment we give, this is what I thought when I initially treated that patient. The patient was an HER2 positive patient. We had treated that patient with chemotherapy and adjuvant trastuzumab. Post 3-4 years, the patient is alive and coming for a follow-up. Even it is a surprise for me myself. So, chemotherapy, without chemotherapy, surgeons don't get a chance, and without surgeons, adjuvant chemotherapy don't get a chance. The team works. Thank you.
Any other questions from the audience? Any want to ask question? Can I have it for the final discussion? Yeah. So we'll continue the session. So we are expecting more questions from the Department of General Surgery. Surgical oncologist is there. and you're all been doing surgeries. I thought you were asking more questions. So we'll have it reserved for the panel discussion. Hope you'll come out with a lot of questions. It was a wonderful presentation.